talking about an overview. There's an overview of ENT. I think we've done this lecture before, but some slight modifications. Usually, evaluation of patients with disease of ear, nose, and throat requires skills in eliciting a good history and examination of the ear, nose, the pharynx, and then the larynx. So the ear, nose, and the ENT, that's basically the ear, nose, and throat. The throat is about the pharynx and the larynx. We'll talk about it as we go. So usually for every clinical condition, you need a good history. So a good and detailed history is usually very important, and it runs throughout medicine. So we take the history of present illness, systemic review, history of past illness, family history, etc. I know all of you know about history taking, so we are not going so much about history taking. This is just an overview. You need to take a good history. Then examination, the patient is made to sit upright on a stool or chair opposite the examiner, and the ears, nose, pharynx, and larynx are usually examined. Sometimes there's a need to examine other systems too. So the ear, I'll start with the symptomatology. So a patient with ear disease can present with any of the following symptoms: either hearing loss. We all understand what we mean by hearing loss. Then tinnitus. Tinnitus is a ringing sensation in the ear, noise in the ear. It can be objective or subjective, usually subjective, because the patient tells you he hears noise in the ear. He hears a ringing sound, buzzing sound, any other kind of sound like in the ear, and that's tinnitus. There could also be vertigo or vertigo, depending on how you want to pronounce it. So vertigo is usually a relative movement between the patient and the environment. Either the person is standing still and the environment is going around, rotating, or the environment seems to be still and the patient feels like he is rotating. People confuse it with dizziness. Dizziness is more like a blackout, but vertigo is it's a relative motion between the individual and the environment. So that the environment is stationary and the person is rotating, or the environment is rotating, the patient is stationary. Or the patient is stationary, rotating, the environment is rotating. There could be ear discharge. The ear discharge could be subclipy, or it could be serous, even bloody. That's a bloody otorrhea. There could be earache, that's otalgia, pain in the ear. Itching around the ear is also a common symptom. Swelling around the ear or a mass around the ear, tenderness, pain, it could be abscess or cellulitis. There could be ear deformity, and there could always be fever. The examination of the ear includes both physical and functional examination. You always know that the ear has physical properties and has functional properties. So you examine the ear physically and you examine the ear for its function. Always remember that the ear it also has functions. Examine, example, the ears use the ear for hearing and balancing. So you have to examine that. Physical examination. The physical examination includes examination of the pinna and surrounding area. So the pinna is the outer earlobe. You look for any deformity, swelling, change of color, tenderness, temperature, differential warmth, or any abnormality. Then you have to examine the external auditory canal, that's the ear canal. This one, you use a speculum or an otoscope. You position it, you put the otoscope through the external auditory canal and try and look through and see the tympanic membrane. There's usually a cone of light on the tympanic membrane. So you don't examine the external auditory canal alone, you examine it with the tympanic membrane. And you examine the tympanic membrane, whether there are perforations, whether there's reddened, whether it's dull, the absence of the cone of light can signify an infection going on in the middle ear. The middle ear, sometimes if there is a big perforation of the tympanic membrane, you can actually see through the middle ear, and you can see some of the ear bones, the ossicles, the malleus or the stapes and the incus. Sometimes you can see a fluid level in the middle ear, which signifies serous otitis media. You also have to examine the mastoid. The mastoid is behind the earlobe. There's a bone, the mastoid process is the bone behind the earlobe. So examine it for swelling, tenderness, differential warmth, because somebody with mastoiditis can present us with ear pain. You examine the eustachian tube. For the eustachian tube, you always have to examine it through there's an opening in the postnasal space. So use the posterior nasal mirror, postnasal mirror, to look at the openings of the eustachian tube. This one is the eustachian tube examination is a bit technical. Facial nerve, I know we all know how to examine facial nerve. The facial nerves pass through the ear, through a very tortuous canal. So you always have to add examination of the ear, facial nerve to examination of the ear. Functional examination of the ear. The ear has auditory and vestibular function, as in for hearing and for balancing. So for the auditory function, use a voice test. If you are talking to the patient and the patient cannot hear, obviously there's a hearing problem. They can do the tuning fork test. I think all of you have seen a tuning fork for, let me see, I think I have one here. Can you see the tuning fork? Hello?
Yes, hello?
Yeah, so this is a tuning fork. Can you see it?
Yes.
Yeah, so you sound it for the Rhiney test. When a tuning fork is sounded, you compare your hearing, the hearing of the patient to you, the examiner's hearing. So you sound it and bring it to the tip of your ear without touching your ear. When you can no longer hear the sound, you send it to the patient to ask whether the patient can hear the sound. And then you repeat the process. If your hearing, you assume the examiner's hearing is better than the patient's hearing. So if you can still hear while the patient can't hear, it means the patient has a hearing loss in that ear. For the Weber test, when it's sounded, you put it on the forehead. For a normal hearing person, you hear it equal in both ears. But for somebody with a conductive hearing loss, it will be heard better in the ear. It will be heard loudest in the ear with the conductive hearing loss. Always remember that. For Weber test, it's lateralized to the ear, to the west ear. The better ear will not actually hear it. The west ear will rather hear the vibration because of the bone conduction. Schwabach test, you are comparing the hearing of the examiner to the patient. Sorry, for Rhiney test, you are comparing bone conduction with air conduction. Rhiney test is bone conduction with air conduction. So when you sound it, you put it on the patient's mastoid. When the patient can no longer hear it, you bring it to the ear. And air conduction is supposed to be longer than the bone conduction. In Schwabach test, rather, I changed it. In Schwabach test, rather, you are comparing the examiner's hearing to the patient's hearing. Sorry about that. For particular positional test, and then spontaneous start. Yes. Am I going too fast?
Yes. Yeah, you are going a bit fast. Could you please talk about the conduction hearing loss regarding the use of the instrument?
Okay. So for Weber test, for Weber, when you sound the instrument, you bring it to the forehead. So Weber is like W. So you are comparing both ears for Weber.
Okay.
Now, for Weber test, it is usually lateralized to the ear, which is the affected ear.
Okay.
You hear it loudest in the ear with the conduction hearing loss. We'll talk about audiology as a whole topic. This one is just an overview. So we will go deep into Weber, Riney, and then the various tuning fork tests when we get to audiology. So for Riney, you are comparing the bone conduction, which is the patient mastoid, and air conduction. You sound it and put it, bring it to the tip of the ear without touching. When the patient can no longer hear, you put it on the mastoid, and as soon as the patient can hear, and then you repeat it. You sound it, put it on the mastoid, and then bring it to the ear. Now, for a normal hearing person, the air conduction is better than the bone conduction. But for somebody with conductive hearing loss, the bone conduction will be longer or better than the air conduction. And for the Schwarber test, you are comparing your hearing. So you sound it and bring it to your ear. When you can no longer hear, you send it to that of the patient. Always assuming the examiner has a normal hearing. Because the examiner too can have a hearing loss. So if the examiner has a normal hearing, then you are just comparing your hearing to the patient's hearing. So it's more of, that one is very subjective. Okay. For vestibular function, you have the positional test and the spontaneous nystagmus. For positional test, you have the Romberg. You can bring the 2 feet together, ask the person to close the eye and see whether the person can stand upright or will be swaying to one direction. You can also do the heel to toe test. Ask the person to walk in a straight line with touching the heels with the toes with the back of the heel in a straight line. For somebody with a vestibular disorder, the person cannot do that. You can also do ask the person to touch the nose and touch the tip of a pen. You are just testing for balancing, for vestibular function. This one, general medicine, I'm sure you've all gone through in general medicine, testing for vestibular function. And then you can also do spontaneous nystagmus. Ask the person to follow a pen or your hand, your finger, to one direction. And then when you stop, you see that the eye will be moving either vertical or horizontal nystagmus. And it's a condition of an inner ear. But the inner ear is responsible for balancing. So if somebody has a problem with the labyrinth in the inner ear, the person will not be able to maintain vestibular function. And ear examination involves physical examination and then the functional examination. Move on to the nose and the paranasal sinuses. So a patient with disease of the nose and paranasal sinuses presents with any of the following symptoms. There could be nasal obstruction, if the nose is congested, and the person might not be able to breathe well, maybe airway obstruction. There could be nasal discharge, which can be mucus or purulent, or sometimes both, mucopurulent. There could be postnasal drip. Postnasal drip is when the patient sits down, the patient feels some fluid trickling back into the throat. That's postnasal drip. It's always a sign of sinus infection, especially the ethmoid sinus. There could be sneezing, epistaxis. Epistaxis is virtually bleeding from inside of the nose. That's epistaxis. Headache or facial pain. Usually for sinus problems, they usually have a lot of headache or facial pains. There could be swelling or deformity of the nose. This one can be obvious, or sometimes you have to examine to see whether there is a swelling in the nose. What we see in everybody's nose is the turbinate. Sometimes the turbinate can be engorged, can be especially for those with allergies. You see their terminates are reddened and very much engorged. There could be disturbance of smell. Now, because of COVID, and disturbance of smell is mostly attributed to COVID. But before COVID, there was disturbance as in anosmia, inability to smell, or sometimes they can smell, but there's a change in smell. They cannot identify which one is what. Usually, without COVID, the disturbance of smell, they usually have nasal congestion. There's usually change in voice too. There could be hyper or hyponasal speech. If the nose is too patent, there's hypernasal speech. And if the nose is somewhat blocked, there's hyponasality. The person is talking, but like the person is talking through the nose. There could also be snoring. We'll talk more about that later. Snoring is usually due to adenoids and then a tonsillar hypertrophy. So for examination of the nose, you examine the external nose for swelling, tenderness, change of color, warmth. So there's usually inspection and palpation. We go to examine the vestibule. This is the vestibule. That's the middle, this is the frenulum. This is the frenulum, this is the vestibule. So the middle, you examine it. You do an anterior rhinoscopy. Anterior rhinoscopy is looking through the anterior nares. And then the posterior rhinoscopy, that one you have to use a post-nasal mirror. Let me see whether I have a post-nasal mirror. I think I do. So this is the mirror. This is the mirror. So you put it through the mouth with a spatula, and then you look at your light source to look at the reflection. The reflection of the postnasal space. You make sure you don't touch the uvula, if not the person will gouge or reject it. Sometimes you have to use a local anesthetic agent like xylocaine spray to prevent gag, to minimize the gag reflex. But once you touch the uvula, the patient tends to gag. Functional examination of the nose, you examine for smell. The nose usually for smell. So you bring different kind of maybe spirits or perfume, bring it to the anterior nares. So you examine for the smell, as you bring different scents to the anterior nares to ask the patient whether the patient can identify those scents. Without the functional examination of the nose. Paranasal sinuses involve the maxillary sinus. I'm actually outside. I was at a conference, so there's a lot of noise at the background, but pardon me. The maxillary sinus, frontal sinus, ethmoid, and the sphenoid sinus. So, and you examine the nasopharynx. The nasopharynx is the space behind the nose. That's the nasopharynx. So a patient with disease of nasopharynx presents with nasal obstruction, postnasal discharge, epistaxis. There could be deafness from tubal blockage. The interstitial tube opens into the nasopharynx. So if there's a mass in the nasopharynx which blocks the interstitial tube opening, the person can present with deafness. There could be cranial nerve pulses. Usually cranial nerve 5, 6, 7, 8, 9, 10, 11, 12 can be affected from diseases of the nasopharynx or nasopharyngeal tumors. Then there could be enlargement of lymph nodes. You see neck. Let me just try and relocate lymph nodes. And usually for nasopharyngeal tumors, they have large cervical lymph nodes. Then we go to the throat. The throat involves the oral cavity, oropharynx, and then the laryngopharynx. Usually when they say throat, people think to talk about only the oropharynx, but the oral cavity and the laryngopharynx are also involved. So the oral cavity extends from the lips to the anterior tonsillar pilus, from the lips to the anterior tonsillar pilus. So the structures are the lips, the buccal mucosa, the gums and teeth, the hard palate, anterior to terse of the tongue, and the floor of the mouth. So you make sure you examine the lips, the buccal mucosa, the gums, the hard palate. You examine the anterior to terse of the tongue. The base of the tongue is part of the oropharynx. And then the floor of the mouth. You ask the person to lift the tongue. You can use a spatula plus a light source, either a head mirror or a headlamp, to examine. If you don't have that, you can even use your pen torch or a torchlight to examine. You lift the tongue, examine under the tongue, and examine all the gums. It's all part of the oral cavity. The oropharynx lies opposite the oral cavity. So the structures involved are the tonsils and the pilus, the soft palate. The hard palate is the oral cavity. The oropharynx is the soft palate. The base of tongue, as I said, and then the posterior pharyngeal wall to examine it for change, color, redness. There could be a bulge in the posterior pharyngeal wall. There could be abscess, cellulitis. There could be deep neck space infection. So a person with disease of the oropharynx presents with other sore throats, dysphagia. So all this in your history of, in taking your history and direct questions, you have to go through all this: sore throat, dysphagia, odynophagia. Dysphagia is difficulty in swallowing. And odynophagia is when swallowing causes pain. So that's the difference. Dysphagia is just basically when there is difficulty in swallowing, but odynophagia, the swallowing will cause pain. There could be change in voice. If somebody has acute tonsillitis because of the hot potato speech, the person is talking like there's something hot in the throat. So there's a characteristic of that voice. There could be earache, otalgia, as in it's usually a referred pain to the ear. The the vagus nerve also has a branch in the throat and a branch to the ear. So usually when there's tonsillitis, they could have referred pain to the ear. There could be snoring when the adenoids or the tonsils are enlarged. They can cause upper airway obstruction. When there's upper airway obstruction, there's usually snoring. Halitosis, that's bad breath. When there's tonsillar abscess, membranous tonsillitis, or when the person has a poor oral hygiene, the person can have bad breath. There could also be hearing loss. As I said, the eustachian tube opens. The opening of the eustachian tube is in the nasopharynx. So if that opening is blocked, there could be hearing loss. There could be abnormal appearance by looking, by inspection, you could just see something abnormal. So examination of the tonsils. For the tonsils, you look for the presence of the tonsils. Some people have undergone tonsillectomy. So not everybody has tonsils. So you even look whether the person's tonsils is present. If it's present, the size, is it enlarged? Is it, how enlarged is it? Moderate? Are they kissing? They can have kissing tonsils. When both tonsils, the palatine tonsils, touch each other, we call it kissing tonsils. And sometimes when they are peritonsillar abscess, you could see the tonsils almost touching each other. Look at the symmetry. If one is bigger than the other, it usually points towards a malignancy. If you have unilateral enlargement of one tonsil, you have to think of malignancy. For usually benign conditions, they both enlarge equally for tonsils because they are both lymphoid tissues. They are lymphoid tissues. but they could have lymphoma, which is the most common malignancy of the tonsil. And usually one tonsil will be enlarged bigger than the other. Look for crypts or membranes. If you say membrane covering the tonsil, you think of diphtheria. In membranous tonsillitis, usually caused by diphtheria infection. Or you could also see ulcers, tonsillar ulcers. You see sores, ulcerations on the tonsil. That one too to point towards a malignancy. There could be a mass on the tonsil or just a bulge. A bulge can point to a peritonsillar abscess. Maybe there's an abscess underneath the tonsillar pilus, and that can lead to peritonsillar abscess. So we examine all those things. You can sometimes even hello, can you hear me?
No, I hear you.
Okay. So examination of the larynx and laryngopharynx. Am I going too fast?
It's okay.
Okay. I'll send you the slides. So I'll send the slide. Examination through your email address. Examination of the larynx. The symptomatology. You can have disorders of voice. You have a hoarse voice. You have crackling voice. You can have painful voice. Some people have pain when talking, and that usually comes from vocal cord. So there can be laryngitis, which usually infection. Tumor, vocal cord tumor, laryngeal tumors usually presents with change in voice. So, and usually laryngeal tumors, that one we'll talk about that separately. Usually any patient, especially a male, presenting with change in voice, hoarseness of voice for more than 2 weeks, you have to rule out cancer. Usually for those females, for those who sing a lot, usually have hoarseness of voice, but it doesn't persist for more than 2 weeks. Once it persists for more than 2 weeks, you have to rule out cancer. There could be respiratory obstruction, upper airway obstruction, and difficulty in breathing, noisy breathing, stridor. When they are breathing, you could hear noises, that's stridor. And that usually points to a respiratory obstruction. There could be cough or sensation of something in the throat. They usually feel there's something in the throat. They always want to cough it out, but they are unable to. There could be repeated clearing of throat because they want to remove something from their throat, but they cannot. There could be pain in the throat or difficulty in swallowing. Usually, if there's a mass in the larynx, it can lead to bulge in the esophagus, leading to narrowing of the esophagus, and it can lead to difficulty in swallowing. And could also palpate a mass in the neck or even the anterior neck, that's the trachea. So examination of the larynx, you have the external examination. External examination, you try and fix the larynx, try and palpate the larynx and see whether it's fixed or you can shift it from side to side, whether there's a grating feeling or you can even palpate a mass. Then you do an indirect laryngoscopy. For that one, to use the laryngeal mirror, as I showed you earlier. You use the mirror, the laryngeal mirror, usually warm it to prevent fogging of the mirror surface. And then you ask the person to breathe quietly through the mouth. You put it through the mirror in the mouth. This one too is technical. If God willing, next year I'm able to come out, maybe take you through it, but it's a bit difficult explaining how to do indirect laryngoscopy with virtual. So you can do a flexible or fiberoptic endoscopy. You have to assess the voice, whether there's a voice change, and then you examine for cervical lymph nodes. Head and neck examination. Head and neck lymph nodes is a different topic on its own, so to be treated, as in the It's an entire topic, but there are various regions of the neck, and the cervical region, posterior auricular region, occipital, the triangles of the neck, lateral, middle, posterior triangle of the neck, and they also have regions. So every region and where they drain, they take their lymphatic drainage from. So depending on which node is enlarged, you can see where the pathology is. For the overview, I think that is that.